Welcome to the deep dive. Okay, you're looking to really get your head around osteosarcoma for revision, and, well, you want the key info efficiently.
Exactly.
Think of this as your focused guide. We're taking your revision notes as our starting point,
Mhm.
and the mission is to pull out that core knowledge, from what it actually is right through to the complications.
Yeah, aiming for a clear and hopefully really memorable overview. We want those facts to stick.
Let's do it. So, straight in osteosarcoma, what are we talking about, basically?
Okay, so osteosarcoma is a primary malignant bone tumor.
Right.
Primary means it starts in the bone itself. It hasn't spread there from somewhere else.
Okay.
Malignant, well, that means it's cancerous. It can invade tissues, spread. It comes from osteoblasts.
Bone-building cells.
Precisely. They start proliferating abnormally, becoming cancerous.
Yeah.
So osteo for bone, sarcoma for this type of connective tissue cancer.
Got it. So the body's own bone makers kind of go rogue, and the notes say it's the most common primary bone cancer.
Yeah, that's a key point. When you're thinking about cancers originating in the bone, this is the one you're most likely to encounter.
And especially in certain groups.
Exactly. Particularly children, adolescents, and young adults. That age link is really important to remember.
Right. And the notes flag a few other key characteristics. Let's try and pin these down.
Sure.
Peak incidence in teens, then another peak later in life, slightly more common in males, like 1.4 to 1.
That's right, yeah.
And where does it usually show up in the body?
Typically, the metaphysis of long bones. Think areas near the ends of the long bones in your arms and legs, like around the knee.
Why there?
Well, that's where bone growth is most active during adolescence, so that might play a role. And although it might not hurt much initially, it's destructive.
Aggressive.
Destructive. And it spreads fast. The notes mention the lungs specifically.
Yes. Rapid metastasis, especially to the lungs, is a real characteristic, something to be very aware of.
Okay. And visually, on an X-ray, there's that classic
A
sign.
sunburst appearance. Yeah. What actually causes that look?
So imagine the tumor bursting outwards from the bone. It lifts up the periosteum, the bone's outer layer.
Right.
The body tries to react by laying down new bone spicules, kind of radiating outwards from the tumor, creating that sunburst pattern. It really shows how aggressive it is.
Wow, okay. And management generally involves?
A combo approach. Surgery and chemotherapy are the mainstays.
Got it. Okay, so that's the definition nailed down. Now, what actually triggers it? Etiology, risk factors. What do we know?
Well, the notes are clear. The exact cause isn't known. That's important. It's probably a mix of things.
But there are known risk factors, things that might increase the chance.
Definitely. Think of them as sort of warning signs in someone's history. Previous radiation therapy is one.
Makes sense. Radiation can damage DNA.
Exactly. High doses to a bone area increase the risk. Then you've got certain genetic syndromes.
Li-Fraumeni.
Yes. And Rothmund-Thomson syndrome. These are inherited conditions that generally predispose people to various cancers, osteosarcoma included.
So like a genetic vulnerability.
Sort of, yeah. And then there are underlying bone diseases, like Paget's disease.
How does Paget's link in?
Paget's messes up the normal bone remodeling cycle. You get areas of chaotic, weakened bone.
Okay.
In a small number of older adults with Paget's, this abnormal turnover can rarely trigger a malignant change into osteosarcoma.
Right. But it's rare.
Very rare. And it's crucial, really crucial, to remember that most osteosarcomas just appear sporadically, out of the blue. No obvious risk factor.
So for most patients, we don't have a clear why. It seems like some cellular mistake happens.
Pretty much. Which leads nicely into the pathophysiology, what's actually going wrong at the cell level.
Yeah, what's the mechanism?
It boils down to genetic mutations, messing with the osteoblast's normal controls. Think of like brakes and accelerators for cell growth and differentiation.
Okay.
The notes mention tumor suppressor genes like TP53, they're the brakes. And oncogenes like MYC, which are more like accelerators.
Right.
If mutations break the brakes or jam the accelerator on, you get uncontrolled growth.
Exactly. Uncontrolled osteoblast proliferation, leading to malignant transformation. And a key feature is that these cancerous cells produce abnormal osteoid.
That's the bone matrix stuff.
Yeah, the unmineralized matrix. But here it's abnormal, forming malignant bone tissue that makes up the tumor.
Okay, so that abnormal bone explains what we see on imaging. Now, if you see something suspicious on an X-ray, how do you know it's definitely osteosarcoma and not something else?
Yeah.
Differentials.
Ah, yes, differential diagnosis. Super important. You have to rule out other things that can look similar.
Like what?
Other primary bone tumors, for starters. Ewing sarcoma, chondrosarcoma. Different cancers, different characteristics.
Okay.
Then there are benign, non-cancerous things. Osteoblastoma, osteoblastoma, they might cause pain, look a bit similar on scans, but they behave very differently.
Right, much less aggressive.
Much less. And crucially, you need to consider metastatic tumors cancer that spread to the bone from somewhere else, like the lung or breast.
So telling primary from secondary is vital. Absolutely vital for treatment.
Hmm.
And how do you tell? Well, the notes stress it's a combination. Imaging, definitely, but then a biopsy is essential.
Taking a tissue sample.
Yep. For histopathology, looking at the cells under the microscope, that gives you the definitive answer.
Okay, makes sense. Let's zoom out again, epidemiology. How common is this, really?
Well, as the notes say, it's rare overall in the UK, less than 1% of all cancers.
So, not common in the grand scheme of things?
No. But again, it's the most common primary bone cancer, and it really picks on that younger group, children, adolescents, young adults.
That peak in the second decade of life, right? Ages 10, 20?
Exactly. Coinciding with those big growth spurts. And that slight male predominance we mentioned, about 1.4 to 1.
Got it. Rare, but a distinct pattern. So what are the first signs? The clinical presentation? How does someone typically show up?
The classic symptoms highlighted in the notes are localized bone pain and swelling.
Just pain and swelling.
Often, initially. The pain might start quite subtly, maybe gets put down to growing pains or a sports injury. But it tends to get worse, becomes more persistent, often worse at night. And then you might notice or be able to feel a lump or swelling over the bone. Think persistent pain and puffiness in a long bone, especially in a teen.
And it can limit movement, too. Notes mention joint mobility issues.
Yeah, if the tumor's near a joint, the pain and swelling can make it stiff, hard to move properly.
Okay.
And another big one is pathological fractures. The tumor weakens the bone so much that it can break with very little force, or even spontaneously.
Wow. Okay. What about general symptoms like fever or weight loss?
Less common initially, according to the notes. You can get them, especially if the disease is more advanced, but usually the first signs are local to the bone.
Right. So persistent bone pain, swelling maybe near a joint, especially in a younger person, definitely warrants investigation.
Absolutely. Red flags.
So what are the next steps? Investigations.
Imaging is key, as we've touched on. Starts with a plain X-ray. You're looking for bone destruction, maybe new bone formation, and that potential sunburst. Then CT scans are really important. They give a better look at the bone destruction and are crucial for checking the lungs for any spread, any metastasis.
And MRI.
MRI gives brilliant detail of the soft tissues around the tumor and, importantly, how far the tumor extends inside the bone marrow cavity.
So imaging paints a detailed picture, but it's not the final diagnosis.
Correct. You need tissue. A biopsy is absolutely essential.
That's the definitive test.
It is. Getting a sample for the pathologist to examine confirms it's osteosarcoma and tells you the subtype, the grade, which influences treatment.
Any other tests? Blood tests?
Blood tests are usually done as part of the general workup, checking things like inflammatory markers or alkaline phosphatase, which can sometimes be raised, but they don't diagnose osteosarcoma specifically. And then, bone scans or PT scans might be used to look for spread elsewhere in the skeleton. And that chest CT is vital for the lungs.
Right, staging the disease properly. Okay, so once a diagnosis is confirmed, how is osteosarcoma treated? Management.
It's a team effort, a multimodal approach, as the notes say. Combines different treatments.
Primarily chemo and surgery.
Yes. Usually it starts with neoadjuvant chemotherapy.
Chemo before surgery.
Exactly. The aims are to shrink the main tumor, kill off any microscopic cancer cells that might have already spread, and often make the surgery easier and more effective.
And the surgery itself? The notes mention limb sparing is preferred.
Absolutely. The goal is always limb-sparing surgery, if possible. Removing the tumor completely while keeping the limb functional.
How's that done?
The surgeon removes the section of bone containing the tumor, plus a margin of healthy tissue around it. Then they reconstruct the gap, often using a metal implant, like an endoprosthesis or sometimes bone grafts.
That sounds complex, but better than amputation.
Oh, hugely better for quality of life. Amputation used to be common, but limb sparing is the standard now where feasible. Sometimes, though, if the tumor is massive or involves vital nerves and blood vessels, amputation might still be the only way to get it all out.
Okay, and then more chemo after surgery.
Yep, that's adjuvant chemotherapy, to mop up any remaining cancer cells anywhere in the body.
What about radiotherapy?
Radiation isn't usually the main treatment for the primary tumor, as osteosarcoma cells can be quite resistant. But the notes mention it can be used sometimes, maybe after surgery, if the margins weren't totally clear, or more often for palliative care, like managing pain from metastases.
So the whole plan is really tailored to the individual case.
Very much so. Depends on the tumor's location, size, grade, and crucially, whether it has spread.
Right. So what's the outlook then? Prognosis.
It really varies. The notes rightly say it depends on several things. Key factors are, has it spread at diagnosis? That's probably the biggest one. How well did the tumor shrink with the initial chemo? And was the surgeon able to remove it completely?
Have survival rates improved?
Oh yes, significantly over the past few decades, mainly thanks to adding effective chemotherapy to surgery. But it's still a serious diagnosis, and the prognosis differs a lot.
And long-term follow-up is needed.
Absolutely crucial. There's a risk of the cancer coming back, recurrence, and also potential late effects from the treatment itself, like chemo side effects or issues with the limb reconstruction.
Okay, which brings us to complications. What can go wrong, either from the disease or the treatment?
Well, the notes list the main ones. Local recurrence, the cancer returning where it started, is a major concern.
And spread.
Metastasis, especially to the lungs, is the most common site of spread, and unfortunately the biggest hurdle to cure.
What about functional problems?
Yeah, definitely. Depending on the tumor location and the type of surgery, you can get limb dysfunction, stiffness in the nearby joint, chronic pain.
And the chemo side effects.
Standard chemo side effects apply things like bone marrow suppression, which means higher risk of infections, bleeding, tiredness, plus potential long-term effects on organs like the heart or kidneys, or even risk of second cancers later in life.
So managing these is important too.
Hugely. The notes highlight rehabilitation, physio, occupational therapy, and supportive care are vital for managing complications and helping patients regain function and maintain quality of life.
It's clearly a tough road. Thanks, that's a really clear walkthrough of the notes. So to quickly summarize for someone revising, what are the absolute must-knows?
Okay, key takeaways. Most common, primary bone cancer. Think adolescents, long bone metaphysis, often near knee. Sunburst on X-ray is characteristic, but not always there. Treatment, chemo, neo plus adjuvant, plus surgery, aim for limb sparing. Prognosis hinges heavily on metastasis at diagnosis and response to chemo. Need long-term follow-up.
Maybe a quick mnemonic?
How about teenage long bone pain plus sunburst? Think osteosarcoma. It's a simplification, obviously, but helps flag it.
Useful. Okay, a final thought then for you, the listener, to ponder as you revise. Think about that contrast, how a relatively localized scar, just pain in a bone, can mask this potential for really rapid, aggressive spread. It underscores why picking it up early and treating it decisively is so critical.
That's a really good point to reflect on, the difference between early signs and ultimate potential.
Right. And if you want more detailed resources, definitely check out the practice questions and other materials over on pastthemsra.com and freemsra.com.
Yeah, great resources there.
Thanks for joining us for this deep dive.